Thank you, Dr. Shweta. Thanks, Arup. Thanks, the other panel members. So, as Arup said, it is just not the intraocular pressure that should lead us to the diagnosis of glaucoma. The most important thing that is required for diagnosis of glaucoma is the structural and functional correlation. And how do you establish that? In this basic clinical talk, let us see how to evaluate basically the disc, corroborate the OCT, functionally correlate with the Humphrey, and then structural and functional correlation forms the cornerstone for the diagnosis of glaucoma. So these are the 7 parameters that should stare at you the moment you look at the optic disc. What are these? Number 1 is the optic disc size. Make a forced decision as to what is the size of optic disc that you are looking at. On the left, you see a small optic disc compared to the size of a Welch-Allyn spotlight. And on the right, you see a large disc. Why the size of the disc is large, we come to know. The next is the common thing that we all know, the optic disc cup, the cup disc ratio, and the vertical cup disc ratio is more important, and the cup disc asymmetry between the two eyes needs to be looked at. When we see 3 normal discs in one picture, small disc, medium disc, and large disc. The lesson that we learn from here is that CDR varies with the disc, with the size of the disc. That is why you must make a forced decision as to what is the size of the disc you are looking at. And cup disc ratio on its own is not significant. What it means is a large cup can be normal for a large disc and a small cup can be abnormal for a small disc. So what stands out is that importance varies with the disc size and it is a surrogate for the neuroretinal rim. What you must look out in the case of glaucoma is the health of the neuroretinal rim, which needs to be pink, or whether there is a pallor or if there is a focal or local notch. And one more important thing you should look out for is the so-called isn't rule, that the inferior neuroretinal rim should be thicker than superior, should be thicker than the nasal, and the last is the temporal. The vascular changes, we all know the nasal shift of the vessel, bearing of the vessels, and the bioneting of the vessels, and the optic disc hemorrhages. Optic disc hemorrhage won't look at you. You have to rule out an optic disc hemorrhage whenever you are evaluating the disc. And the nerve fiber layer defect, it touches the optic disc and fans out into the periphery, better noted with a red-free light. The peripapillary atrophy arising de novo can be pathognomonic of glaucoma and not a pre-existing one, and the chorioretinal degeneration can suppress the sensitivity overall in the Humphrey visual fields. So after seeing this, how do we corroborate with an OCT here or RTVO printout? It is the combination of the RNFL thickness and the optic nerve head shape that increases the diagnostic power. The ganglion cell complex is also an important, significant factor in the RTView machine. This is the normal printout. You must corroborate the patient details, the test net graph, and the summary table. And then comes the functional correlation after establishing and corroborating the structural defect. This should match out with the functional changes in the visual field, the 8 important segments of the visual field that you must know. And when you, in one slide, try to discuss the visual field, on the left you see there is dense suppression in the total deviation plot. When the diffuse suppression is cut off from the total deviation, what stands out as the normal points in the pattern deviation can be a pure case of cataract. What you see in total deviation significantly being persistent in pattern deviation can be frank glaucoma. Total deviation is fully suppressed. Focal defect spanning out in the pattern deviation can be a cataract and glaucoma. This is how basically, because of the paucity of time, in one sentence I'm interpreting the visual fields. And now the structural and functional correlation. Basically, I told you the size of the optic disc. Here you see a large disc with a large cup. 3 decades back would have been a glaucoma case, no longer anymore, because the health of the neuroretinal rim is not good and the visual field is normal. Here if you see there is an inferior temporal notch manifesting as a focal defect in the superior nasal step. Here if you see there is a dense excavation in pallor of the superior optic nerve, optic rim, which manifests as an inferior arcuate defect. In this case, if you have to differentiate between the color cupping and the contour cupping. If you see carefully the dipping of the vessels, there is a wide near total contour cup manifesting as a dense defect in the visual field. These cases should be done, repeated with a 10-2 printout to have a proper follow-up prognostic value for the visual field. And invariably, whenever you detect a temporal pallor of the optic disc, don't be surprised if you get a hemianopic quadrantanopic defects. This is the other eye. So in the case of bilateral pallor, always subject these patients to a Humphrey visual field to rule out any neurological deficits. Here, if you see, there is an inferior temporal excavation. If you see carefully, there is a retinal nerve fiber layer defect which is spanning out into the periphery. Corroborate with the OCT, there is an inferior temporal thinning, significant ganglion cell loss, correlating exactly as a focal defect in the superior nasal step. This is exact the structural and functional correlation that you need to establish for the diagnosis of glaucoma. Here if you see there is a inferior excavation of the neuroretinal rim and a possible small superior temporal thinning as corroborated in the OCT manifesting as a then superior arcuate defect with encroachment into the macula and then the focal defect in the inferior nasal step corroborating with the superior temporal segment in the OCT. This is how you have to correlate structural and functionally to establish the diagnosis of glaucoma. Hemorrhage, as I told you, never looks at you. Rule out a hemorrhage. Here you see a hemorrhage in the superior temporal segment. Initially, the normal OCT, normal visual field. 3 months down the line, if you see the visual field on the right side, there is a slight one spot defect in the inferior nasal step. This is how you have to follow up the patient and try to manage a case of glaucoma. Last but not the least, this last case I would like to show. Like this is my learning the defect, the learning curve in the interpretation of the OCT. When I had the machine, like just because there was a difference of 19 and 14 between the two eyes, I just subjected this patient to a visual field and then the OCT. I detected in the right eye superior temporal and inferior temporal the thinning. Then I went back, had a relook at the right eye, then I started seeing some sort of a RNFL fiber layer defect there. Then I learned about the GCC complex in the RTView printout. After 4 months, called the patient back, the superior temporal and the inferior temporal segment is no longer there. Go back and review. In the month of April, there was a STIT segment thinning. In the month of November, it is no longer there. What is the reason? If you see the centering of the test done, in April, the test done was decentered, a more peripheral point was tested, and that was the reason for the superior temporal, inferior temporal defect. Whereas in November, 6 months down the line, when we repeated the test, the centration was perfect, and there was no nerve fiber layer defect detected there. So, according to the OCT, the imaging technologies do not confirm the diagnosis by themselves. Imaging technologies at best only complement the clinical judgment of the glaucomatologist. Structural and functional correlation by stereo photographs and visual fields is a vital tool. A good collaboration with the relevant imaging technology does act as a bonus. Thank you very much for your